So our next speaker, Dr. Jane Marke, originally trained in internal medicine at Montefiore Hospital before switching to psychiatry, and did further training at St. Vincent's Hospital with fellowship training in consultation liaison psychiatry at Long Island Jewish. Seeing that not all her patients got better with traditional pharmacology and psychotherapy, she began exploring the importance that micronutrients played in mental health. She became board certified in holistic and integrative medicine, noticing that many patients had been exposed to Lyme and other pathogens, and that they often presented with physical symptoms. She began studying the pathogenesis of these fascinating, insidious creatures. Over the years, her practice has tended to specialize in patients with tick-borne disease. She's taken several courses on tick-borne diseases and did 2 preceptorships in the treatment of tick-borne disease. She's been in private practice in Greenwich Village for over 30 years. Dr. Marke regularly consults with primary care doctors in the diagnosis and treatment of patients with tick-borne disease. Dr. Marke.
So I want to thank Barbara more than anybody for having pulled this entire day together and having taken the group of us from being a task force in complementary and alternative psychiatry to being a committee and having the budget to put on this afternoon. And I want to thank all of you guys for coming out here on a Saturday to try to find out-of-the-box treatments for your treatment-resistant patients. Let me just get settled. Okay, so I'm going to be talking to you about microbes and mental illness. And I'm going to be focusing on tick-borne disease because that's very much what you're seeing. And I will teach you when to suspect it, how to detect it, and a little bit about treatment. So it's really important that we begin to think about psychiatric diseases as chronic diseases and stop thinking about them the way we've been taught to from the DSM model. We've been taught to think about syndromes, and our treatments have been geared at symptoms. But if we start thinking about our patients as having chronic illnesses, then we're thinking in a medical model that forces us to think about etiology and not just symptoms, and puts us much more in the mainstream of where medicine is. This is very much what the CDC is saying these days, that many illnesses are caused by microbes, even if we don't yet know what they are. Stealth microbes are the microbes that are important here. And these are the ones that stay and persist in our system. And they do that by evading and suppressing our immune system. So these are not things that we really think about when most of us were trained in medicine, in medical school. Stealth microbes were not a kind of microbe, but they are. And HIV, chlamydia, mycoplasma, these are all on that list. Herpes is, and now Borrelia is. And there's a different way of thinking about illness when we think about chronic illness and stealth microbes. We all learned the Koch hypothesis that any particular bacteria could be implicated in an illness if it caused that illness in a replicable way over and over. So one bacteria caused one group of symptoms. Well, it doesn't work that way with stealth microbes. And here we use something called the damage response framework. And this is important these days in the way we think about chronic illness. And the damage response framework is that any illness is the outcome of an interaction between the host and the offending agent, whatever it is, whatever the threat is that might provoke damage. And both the immune system and the neurological system are geared to respond to danger. They're not looking for other, which is how we were sort of brought up, many of us. They're looking for danger. So it's very frequently the host that produces the illness and produces the damage. It's not the microbe. There are loads of microbes that have done very well with us and been integrated into our DNA and don't cause us any problems, and our immune system hasn't reacted, and they've become part of us. it's only if there's a threat of damage by the microbe that the host responds. So some of us are old enough to have been trained in syphilis. And so if you do remember syphilis, you remember at a time when all psychosis was syphilis and dementia was syphilis. And syphilis was actually the first stealth microbe. You became infected with it and you might become demented 40 years later. And Lyme is a spirochete that's way more evolved than the syphilitic spirochete. And I'd like to say now, think Lyme. So what is Lyme? Well, there are over 300 strains just of Borrelia burgdorferi, and there are many other Borrelias. People think of it as being carried by the deer tick, but it's not just found in the deer tick anymore. The Lone Star tick, the dog tick have all been found to carry it. Most people who have Lyme disease are better thought of as having tick-borne disease, TBD, or Lyme-associated disease, because they're infected with multiple microbes. It's a disease that affects every organ. And the Borrelia spirochete is just an incredible organism. It has the longest chromosome and more genes than any other organism that's been identified. Oh, and I do want to say that it's pandemic, and that you can find it anywhere. And that's an important thing to know. If you really want to learn a lot about how to diagnose it and what the standards are for Lyme, I advise you and recommend that you go to guideline.gov. That is the National Clearinghouse website that the Institute of Medicine sponsors, and that has guidelines for both diagnosis and treatment. If you go to the CDC website, you will find criteria for public health surveillance and not diagnosis. And there's a great deal of confusion about using CDC criteria for clinical reasons. But the guidelines that the government does support are on guideline.gov. Need I say more? These are your treatment-resistant patients, some of the sickest. Probably all of you have seen a Lyme patient but don't know it. An important thing to know about the ticks is that when you get a tick bite, you don't just get one organism. People think about Lyme, but people who are infected with Lyme also very commonly have babesia. They get infected with worms because the eggs of nematodes are carried by ticks. And these are other diseases that you will get from what we consider to be the dirtiest needle around. The natural history of untreated Lyme, it's really very much like syphilis. There may be an early lesion, or there may not be an early lesion. And the early lesion for Lyme is the EM rash, and that's the bullseye rash. But only 40% of people get it, and most people don't remember a tick bite. The rash occurs about 10 days after the tick bite. There can also be a flu-like syndrome. That's really important. I have had a patient miss a session in August because he had a flu with 103 fever. And I thought, well, there isn't any flu going on right now. And he had been hiking the prior week, and it did turn out that he had Lyme. And he was a psychotherapy patient, and he wasn't going to see anybody for that. Secondary Lyme is early disseminated, and the Borrelia spirochete gets into the CNS very, very quickly. It gets in within about 10 days or so. And at that point in time, if you get nervous system symptoms, they can be really devastating: meningitis, cerebritis, vasculitis, carditis. Mostly we see cranial neuritis and we see Bell's palsy, but a lot of tinnitus and vertigo. People look like they have Meniere's. This lecture, I'm going to really focus on tertiary Lyme, and that's where you get encephalopathy. These patients also may have arthritis, but they really have a lot of neurological symptoms, and that takes months. Neuroborreliosis is just Lyme affecting the brain, but we also know it as encephalopathy. An important thing to know about the Borrelia spirochete is that it exhibits something called tissue tropism. And that is that it has proteins on its cell membrane surface that take it to specific areas in the body. And these are mostly immune privileged areas, but it really has a very great affinity for nerve cells and microglia. It also likes cardiac muscle and cartilage, but we're going to focus on the nerve cells and the microglia. Co-infections also contribute to the brain dysfunction, and mostly it's Babesia, Bartonella, and Brucella that are the culprits here. You might want to know, why am I focusing on Lyme in a psychiatry talk of all of the microbes? Well, there was a study done in Czechoslovakia that found that there was a 33% incidence of Western blot positivity in a psychiatric population compared to a healthy population. And this is using the very strict CDC surveillance criteria. And then the same group looked at inpatients and found that out of 900 inpatients, 300 of them met the CDC criteria. And when they looked at what their ICD-DSM diagnoses were, they were a complete match with the patients who did not have the Western blot positivity and clearly did not have neuro-Lyme. And so that meant that they could have any syndrome that you might see, which is why I'm thinking of this talk as being about treatment resistance for just about any psychiatric disorder. I know there's been a lot of talk out there, you know, because of controversies about diagnosis of, do people really have chronic Lyme? Does it really do this? And I just want to say that everything I'm going to say is evidence-based, and there's a very large peer-reviewed literature, and you're welcome to look at it. Robert Bransfield, you know, is constantly doing PubMed searches and coming up with what the statistics are, so this slide is courtesy of him. But I have lots of bibliographies that you can all have access to see that this is all evidence-based. So stealth microbes persist and they cause symptoms. How do they do that? Well, I'm going to be talking about what the pathophysiology is now. So first is, you know, what's the direct invasion of these bugs? Well, they adhere to blood vessels. They have a lipoprotein molecule on them called OSPA, which is a fascinating kind of protein. But one of the things that it does is it makes it adhere to the tissue that it wants to adhere to, which one of them is blood vessels. So it gets carried along, it adheres to blood vessels, and it stays there. It resists the flow of blood, but it can travel on blood vessels, and that's how it travels to produce the EM rash. It disrupts the blood-brain barrier very quickly. It disrupts the junctions between cells and widens them so that you can get diffusion of toxins into the brain, as well as the Borrelia and other bugs also. It has an affinity for glial cells and neurons, as I said, and it will stimulate innate immunity, but it evades the complement system. It makes itself invisible. So while it stimulates Th1 immunity, it doesn't really get killed very, very frequently. And it suppresses humoral immunity. Many of our patients are diagnosed as having combined variable immunodeficiency syndrome because they stop making IgG. It lives in and out of cells, and it loves matrix tissue, which is another place that there's not a big blood supply. It changes shapes, and this is very interesting, and some of you may know about this, that, you know, this corkscrew kind of thing will collapse itself, form a round body, secrete a waxy substance, and be virtually impenetrable to antibiotics and to our immune system. It will also form round bodies that lose their cell wall, and so they're kind of like floating organelles. It lives in biofilm where they communicate with each other. The flagellum I love because, we're used to thinking of a flagellum as sort of a tail that would be on the end of a sperm. This flagellum goes all the way around the corkscrew, and it acts more like the wings on a corkscrew does in giving a huge amount of power to propel the bug, and it can be propelled through cells. So we're going to be thinking about it. The diseases that it causes is chronic, but also inflammatory. Our psychiatric disease is inflammatory. There's a lot of literature on cytokines and psychiatric disorders. And there's always a question of which came first, the chicken or the egg. And there's a great naturalistic study being done in Avon, England, where they've been following children and their parents over the course of over a decade now, and they found that children who had a high IL-8 at age 8 had, I think it was a twofold chance of developing, an 81% chance of developing depression and a twofold chance of becoming psychotic by the time they were 18. And that's pretty striking. They also did a meta-analysis of anti-inflammatories and depression, and what they did was they analyzed a lot of studies of people who were being treated for arthritis or Crohn's disease with drugs like Humira, and they discovered that the depressions of these patients went away, whether or not their symptoms did. So in Lyme disease, we get activation of the microglia, and we get a huge outpouring of interleukins and cytokines. And normally this would progress and activate adaptive immunity, but this is not going to occur here. So what ends up happening is you get high levels of interleukins, both in the CSF and peripherally, and they continue and they continue and they continue. And there is just no end to this because there's no wiping away of the stimulus. So what ends up happening is we get nerve death, and neurons start dying, and they die pretty quickly, and they die over a long period of time because it's a kind of a bystander effect to the inflammatory environment caused by the outpouring. Another problem that we have is that we get an impaired hypopituitary axis, and this becomes a self-perpetuating cycle of inflammation. And we are talking about inflammation in the brain here. This could apply to other things, but for us, this is all about the brain. So the interleukins will stimulate the hypothalamic pituitary axis, and when this is done on a chronic basis, it becomes depleted, it loses its substrates, and we get hypopituitary axis failure, and we get low cortisols, which contributes to more inflammation. This is a picture of a spirochete inside a neuron in the brain. The next mechanism by which we get mental illness from Lyme disease is neurotoxins. So the interleukins stimulate indole Diogenes, and that's what helps convert tryptophan into serotonin. So instead we send tryptophan down the kynurenine pathway and end up with quinolinic acid. And quinolinic acid is highly neurotoxic, and it's been found to be responsible for depression and encephalopathy. And it really probably isn't the low serotonin, which is, kind of seductive to look at, but that probably isn't really the problem here. High levels of quinolinic acid have been found in the CSF of patients with CNS Lyme. And I'm going to separate out those from really having encephalitis and meningitis, and those who have encephalopathy. It was high in both groups. It was less high in the encephalopathy group, but it was elevated. And in addition, the encephalopathy group has a higher serum quinolinic acid. And that's something that's not hard for us to measure. We also get nitric oxide production. And overproduction of nitric oxide causes more oxidative stress and causes neurodegeneration. Another problem that we have is we have disturbed homocysteine metabolism. And when we have disturbed homocysteine metabolism, we end up with a problem with the balance between free oxygen radicals in the mitochondria and the, all of the antioxidants. So one of the ways in which homocysteine does this is that it suppresses remethylation. And it's important to know because the apoptosis that homocysteine causes can be reversed and stopped by the administration of SAMe. So that's an important thing to be aware of. And another really important mechanism, especially in children, is molecular mimicry. So the OSPA, which again is my favorite lipoprotein, that stimulates antibodies which cross-react with human brain. The spinal cord, the dorsal root ganglion, and also the basal ganglion. And there was a study done of post-Lyme patients with persistent symptoms. And now, this is sort of a dog whistle. When we hear, when you look at a study and it's talking about post-Lyme or post-Lyme syndrome, and even if it's talking about chronic Lyme, as opposed to talking about late Lyme or persistent Lyme, there's usually a bias that's implicit in the authors, that they have a belief that 3 weeks of antibiotics early in the disease means that you no longer have Lyme disease, and any symptoms you have are post-Lyme. So these researchers set out to prove that there were antibodies that were persisting even without an organism. And they found that 50% of the patients that they studied who had persistent symptoms post-Lyme had anti-brain antibodies, as opposed to people who were treated for Lyme and were feeling well, where it was 16%. They concluded that this didn't have any meaning and that they don't know the significance of it, but I think that those of us who are seeing patients with persistent neurological symptoms would be really concerned about this. And another study found anti-ganglioside antibodies. These antibodies aren't the kind that you find in an autoimmune disease. In autoimmune disease, we get antibodies to the organelles inside of cells, like the nucleus, but these are antibodies to the cell surface. So they're somewhat different from what we see with autoimmune disease. There was a vaccine that was made using the OSPA, and it was taken off of the market, and what you might hear in the popular press is that it was taken off because of lack of demand, but it was actually taken off because a lot of people got sick from it. And if you look at this, that, you know, antibodies are formed to OSPA that cross-react with nerve, you could see why a lot of people got sick, and that's probably why there wasn't a big market, that people were not doing well. There's also mitochondrial damage. And the mitochondrial damage is a result of the constant inflammation. And there's a lack of formation of glutathione because Borrelia actually interferes and competes for cysteine, and it takes up cysteine. And if it takes up cysteine, then we can't make glutathione, which is what we really need, so that we neutralize our free radicals and our superoxides. You know, and results of mitochondrial damage are going to be things like fatigue and depression. So, you know, so if we sum up all of these mechanisms, it's cytokines, neurotoxins, antibodies, and mitochondrial damage. And so those are the ways that we have to look at our treatments in addition to whatever antibiotics we use. And we can match this up a little bit with what kind of symptoms people present with. A lot of you know that people don't get better all so quickly, and a lot of people relapse, and that is because, to a large extent, because of co-infections. And so this is just what New York State has looked like recently in terms of ticks, and 70% of our ticks are infected with Borrelia, and 30% of them have 2 organisms. These are the major co-infections that we're going to be seeing, and the ones that are of importance and real interest to psychiatrists are Babesia and Bartonella, and they cause different psychiatric complexes. Our Babesia patients have a lot of anxiety, panic disorders, and depressions, while Bartonella patients more OCD, self-mutilating, rage attacks, and psychosis. And under psychosis, it should be bipolar disorder. So there is a controversy, as many of you know, about do these organisms persist? And there's a lot of evidence of people improving with antibiotics with both late Lyme and retreatment after being treated with only short courses. There are a lot of references to support persistence, but there are living organisms that persist, and they provoke the release of the cytokines both in the CNS and peripherally. And the atypical forms, while they're sort of metabolically fairly inactive, they still drive local inflammation. By the time people get to us, they have late Lyme. So that's by definition. So if they have late Lyme, they already have a very high allostatic load. And this is where thinking about the damage control framework comes in, because it's really about what kind of immune system does somebody have, what is their organismic resiliency in being able to deal with this organism, that's going to really be part of determining the outcome of how they do. And so what that means is that treating the organism may not be sufficient if you have somebody who can't sleep and has non-restorative sleep, or who's dealing with tremendous family stressors because nobody really believes they're ill or doesn't understand their complaints, and has a lot of other stressors in their life. The allostatic load is very high and the resiliency is very low when we're seeing them. So we're seeing encephalopathy, neuropsychiatric syndromes, and our patients often have neuropathy also, but I'm not going to deal with that specifically. That's what I'm going to be talking about next, is encephalopathy. And that's ubiquitous in late Lyme. Statistics show that 90% of patients with late Lyme have encephalopathy. So, what does that mean? Well, neuropsych testing shows that these patients have problems with ordering, verbal fluency, processing speed, and motor programming. And I think of that as kind of like an apraxia, that even when they can sort of find the words, they frequently lose the fluency of being able to get them out with a normal cadence and rhythm. And the same thing can happen with motor behavior that is normally automatic. It loses its fluidity. Balance becomes disturbed in a sort of different kind of tippy way that comes from this. But there are findings that are very specific. But what do the patients complain of? Well, if they're feeling sick, they often will say that they have brain fog. And they'll put that kind of label on themselves. And they'll say, well, I feel like I've got green pea soup in my brain. But if they don't know that they're sick, they may come to you complaining of symptoms of ADD, because they have cognitive inefficiencies and cognitive problems, and they can't focus well. So those are really common complaints that will show up in your office. Another thing that happens during this is that people are often very sensitive to lights and sounds and feel overstimulated easily. So these are other questions to ask. The MRI and CT scans of these patients are nonspecific but show vascular involvement, which fits in with the pathology because we know that the organisms are living in the blood vessel walls. And the SPECT shows areas of hypoperfusion. And this can be diffuse or it can be mainly in the parietal and frontal lobes. You know, one of the things is, you know, a question might be, do I order these tests? And I will say I don't order MRI or CT. I do order SPECT. I generally send my patients up to Columbia because Brian Fallon started looking at these ages ago, and I think they have the largest collection of patients. So I tend not to send them to the private SPECT places, but to Columbia. And I don't generally do it for diagnosis. I generally do it because somebody is so sick that I feel like I really want to be able to prove it to doctors that I'm hoping will give them intravenous antibiotics, which is something that I don't do. And it may be to prove it to their family or to prove it to themselves. But generally, I can make the diagnosis without the abnormal SPECT scan. This is another study which was designed by people who wanted to prove that there is no such thing as late Lyme causing psychiatric problems. So they studied 58 adults with chronic Lyme and 26 without. And these were people who had met the CDC criteria but had been treated. And what they found was that, you know, the adults, what was the percentage here? Well, I believe it's 33%. I'm trying to, yeah, 33 patients out of, compared to, okay, let me just put it this way. Compared to the controls, because I'm getting confused as to whether that's a number of patients or a percent, but I think it's a number of patients. These patients met criteria for ADD, and they met criteria for both inattentive type and hyperactive impulsive type. And they did not have this in childhood. Now, the conclusions of this study were that patients are being misdiagnosed as having chronic Lyme disease when actually what they have is ADD. And I'm here to try to get you guys to think in the reverse way, that instead of taking something where we're looking at a disease with an etiology and turning it into a syndrome, let's look at our syndromes and see if we can find an etiology. So I think that the take home from this study is that if a patient comes to you in adulthood saying, I think I've developed ADD, and I'm here hoping that you give me some Adderall, that you think, well, wait a minute, why are they getting ADD in adulthood? And you look more deeply to try to find an etiology. What causes the encephalopathy? It's cytokines, and it's also quinolinic acid. They're both elevated in patients who have encephalopathy, and there are a lot of studies that show that. Sleep in Lyme is extremely disturbed. They're about the worst sleepers I've ever seen. These are patients who can't fall asleep, who wake up during the night, who are not rested. Some of them have alpha wave intrusion, which is a cause of hypnagogic and hypnopompic hallucinations. Some of them get diagnosed as having narcolepsy. Sleep deprivation contributes to the allostatic load that they are bearing. It interferes with mitochondrial function. It causes mitochondrial stress. And it actually damages the mitochondria of the locus ceruleus very specifically, which isn't a place that you want to see your mitochondria fail, where you're filtering and paying attention and have your neurotransmitters that have to do with executive function, that are below the cortex. Beta amyloid is cleared out of the brain during delta sleep, and it doesn't get cleared out in these patients. We know that there's cortical atrophy when you lose sleep quality and non-restorative sleep, and we don't have removal of neurotoxic waste products. And there was actually a study that I just read that showed that one night of pulling an all-nighter ended up producing in the serum of the study people, substances being released from the cytoplasm of the neurons, indicating that there was neuronal loss during the night because they did not have the opportunity to clear the brain of the toxins that were accumulating during the day. And that was like just one night of an all-nighter. Depression is very common. There have been a lot of studies on it, and the percentage of depressed patients ranges from a low of 37 to a high of 80. And that compares very unfavorably with what the lifetime prevalence is in the general population. Suicide. There's not much in the literature on suicide. If you were to do a PubMed search, I think you'd come up with about 4 studies. Some of them are case reports. There are studies of the new onset of suicidal thoughts. Brian Fallon and Robert Bransfield see the most patients with psychiatric symptoms of Lyme of any 2 people in the country, I think, and they've both done a lot of presentations addressing the high suicide rate among these patients. I think the best way of getting a sense of the risk of suicide is from the newspapers. And if you just sort of pay attention in the newspapers, this came to me. This was the Perth newspaper in Australia. 6 suicides. Very quickly, this woman, is one of our doctors, and her suicide was published recently. If you look closely, you'll see she has a Bell's palsy, which is a very good indicator of Lyme. A study of children who have Lyme disease showed that 40% of them have suicidal thoughts and 11% made gestures. We have a population of children who are getting increasingly sick. They play in the grass. The ticks are spreading the Lyme bacteria everywhere. They're carried by songbirds, and so it's all over. Even kids that play in the city, in Central Park and Prospect Park, they're getting exposed because the songbirds are dropping the ticks. I even had 2 patients whose only possible exposure was the Christmas tree that they brought in Christmas. And so children are getting very ill, and they're suicidal. This was the first case of treatment of Lyme-induced depression with antibiotics. He got better. This is a patient of mine who presented with anxiety. I thought of her as a psychotherapy patient. Turned out that she told me she had a panic attack during a date, but she actually had passed out. Although she hadn't called it that, she'd passed out 3 times. She's in her 20s. She'd passed out 3 times in the last few years, all with change of position. So I took her blood pressure, and she was markedly orthostatic and tachycardic when she stood up, which is very suggestive of Bartonella. So I sent off bloods for testing in her, and the Western blot came back suggestive but not positive, but she did come back as having one of the co-infections, which said, yes, this woman did have a tick bite and got infected. And she's now on antibiotics. Intrusive symptoms are very common. Musical hallucinations and intrusive thoughts. A lot of musical hallucinations. It's way more common than you would think. It's a lot more than just having an earworm. Catastrophizing, just horrible thoughts. You can kind of think of some of them as like cognitive tics. OCD symptoms. Leah is a girl who was referred to me because she was known to have Lyme disease, or thought to have Lyme disease. She had OCD. She couldn't even take an exam because she needed to have symmetry in how she filled out the answers from A to E. She has Bartonella, and she's gotten so well that she's going back to her senior year of high school next year, and she hadn't really been in school since 6th grade. Pediatric autoimmune neurological disorder is important to be aware of. This is a dramatic, sudden onset of OCD-type symptoms or Tourette's-like symptoms. Usually, it was always considered to be a disorder of childhood. Originally, it was thought to be caused by type A hemolytic strep, but now we know it's caused by a lot of different organisms, and we know that it also occurs in adults. So there's a sudden onset. The criteria have been laid out by the consensus committee, and they've also published what they think the PANDA workup should be, which we also think about as being a Lyme antibody workup. So this is an autoimmune disorder. This is actually molecular mimicry that I had described, and this is how molecular mimicry tends to present. Dr. Ray Charles sees most of the patients who have this, and he says they do extremely well with antibiotics, and if they don't, they get immune globulin. Depersonalization is extremely common in this group. You have to ask. People don't volunteer it. Violence and self-harm, again, you get more of a sense of that if you pay attention to the newspapers. Adam Lanza, a typical case. I have here the daughter of one of my children, Lila, who began having temper tantrums when she was 3. But such temper tantrums that she would just practically destroy her room, and then afterwards she would cry and say, "I'm a terrible kid, I'm a terrible person, how could you love me?" I've ordered 2 sets of Western blots on her over the course of time because it just doesn't fit that this girl, who generally has good ego function, has had such huge temper tantrums. And last month she had a psychotic episode. Her testing is now flagrantly positive, as well as positive testing for Bartonella, and she was just discharged this week from 4 Winds and will be in a day treatment program. And it clearly started early. There are cases of schizophrenia. Rosalie Greenberg sees a lot of kids in New Jersey who have tick-borne disease. Autism spectrum disorder. There is vertical transmission of Lyme from mother to fetus. There's no blood-brain barrier in the fetus, and these children are born with various problems. I'm not a specialist in all of them, but I will say that autism does seem to be one of them. And in this study, 5 children with autism who were positive on the Western blot were treated with antibiotics, amoxicillin and azithromycin, and they made remarkable improvements, just remarkable. We're also finding spirochetes in Alzheimer's disease. We've been finding them for a really long time. It just hasn't gotten into the clinical wisdom that there are infections here. McDonald and McCloskey are the pathologists who are doing the studies. And they looked at spirochetes in the brains of Alzheimer's patients, and there are lots of spirochetes, all kinds, especially oral spirochetes, and the thinking is that many of the organisms that get into the brain that are stealth organisms that hang around for a long time get in through the olfactory bulb. Beta amyloid plaques are the brain's response to microbes, and there are microbial biofilms that are at the core of these plaques. There are other organisms that increase the chance of Alzheimer's, and it has been found that there's a 5-fold increase of Alzheimer's if you have a chronic chlamydia infection, a 4-fold increase if there's evidence of spirochetes. All psychiatric syndromes are worse with co-infections. There are a lot of provocative findings. I'm going to go faster. Diagnosis. Take a history. Take a medical history. I don't usually believe in checklists, but I do use checklists for this, and I have patients use them before they come in to see me. And I have a downloadable one on my website. Mental status exam, be sure to ask about the intrusive thoughts, the depersonalization, any ADD in adulthood. And I recommend a neuro exam Take your patient's blood pressure sitting and standing, look for asymmetries on their face, for cranial nerve abnormalities, look for cerebellar findings. It's very easy and very quick to do that. You can check their reflexes. That would be helpful if you find that they're missing and that they have neuropathy. But the most important thing, I think, is to take their blood pressure. You'll find that a large number of people get orthostatic who you didn't expect. CDC guidelines, as I said, that they're really meant for surveillance. They're not good to use for the population. The ELISA is a 50-50 and the Western blot is a 50-50. Those of us who are taking care of patients with Lyme disease, we look at the bands that are specific for the Borrelia bacteria, and we say if a patient has one of these bands, it indicates that they've been exposed. The CDC says don't look at the IgM band, and that's wrong because the IgM goes up and down over the course of the chronic illness. When people have exacerbations and they're sicker, they may make more IgM, and IgG is often suppressed, but these wax and wane, so at different points in time, people are going to have different results on the test. If they show that they have exposure, that's the most important thing. Other Lyme tests to do, the only one that we can do in New York is the PCR. The other tests are all accepted in every other state in the union, but they're not accepted here. What lab to use? You can use any CLIA certified lab. The FDA does not certify labs. That's important to be aware of because they're trying to extend their mandate to regulate labs and get rid of what they call mom and pop labs, so that all we will have will be academic labs and LabCorp and Quest. But there are wonderful microbiologists and chemists who have set up fabulous labs, and they're not mom and pop labs, and they are CLIA certified. Most of us like IGNX, and the reason that we like it is that it reports the bands. Anybody that doesn't tell you the bands isn't really helping you. And IGNX uses more than one strain. The other labs just use the B31, which is a lab strain. It's not the strain that most people have. And there are so many strains, it's important that the lab include as many as possible. Supplementary blood tests are basically all about inflammatory markers and some that are specific, that we find specifically here, like the VEGF, which is a vasoactive growth factor that we find is often high in Bartonella. So case by case on the right, and what I suggest that you do is a screening test if you're suspicious on the left. Treatment. IV treatment of encephalopathy is safe and efficacious. This is a SPECT before and after IVs of encephalopathy. You can think of that also as before and after treatment of ADD with antibiotics. In terms of randomized placebo-controlled studies, we don't have any. There are 4 open label studies, and there are studies on IV ceftriaxone. There are some studies on oral doxycycline, and basically oral drugs are effective, and most of us will use oral drugs, but the studies have been done on IV drugs. Minocycline probably penetrates the blood-brain barrier the best. From a CAM standpoint, these are the things that we do to improve the host and to improve the terrain. We want to improve both phase 1 and phase 2 detox. In terms of supplements, N-acetylcysteine and glutathione are very important. People feel dramatically better, and you can see the pathophysiology behind that. There are a number of substances which decrease activation of microglia. Low-dose naltrexone is excellent for this, and people often have a greater sense of well-being from it. Skullcap is great, turmeric is great, and cannabidiol is also something which has been shown to stabilize the microglia. You can aim also at reducing the release of cytokines. And there are other neuroprotectants. Some of these are drugs and some of these are foods, but they're foods that have been made into herbs that can be taken. We can lower glutamate exciticity, and these are things that do that. Galantamine can be taken as a supplement, acetyl L-carnitine, and N-acetylcysteine. Low-dose naltrexone is really helpful. It improves the inflammatory reaction and immune function and increases a sense of well-being. And the dose that's effective is, maybe 4.5 milligrams. It's also been shown to potentiate antidepressants. Symptomatic treatment is what you already do in your practice. So what should a psychiatrist do when you have a treatment-resistant patient? Think microbes. What should a psychiatrist do when a new patient comes into your office with a major illness? I think you should think microbes then also, so do the checklist. Thank you. And I specifically also want to thank the people who helped me by loaning me slides, like Dr. Robert Bransfield, and I want to thank iLads, which is a fabulous educational organization for Lyme disease. And we'll take questions.
You want to take a few questions? Go.
In your experience, what percentage of patients have had a prior history of mono?
I don't think it's different from the general population. However, because of immune dysregulation that occurs, there's reactivation of a lot of viruses. So a lot of my patients have very high levels of herpes viruses, of mycoplasma, of a whole lot of other organisms. So I'm not sure that they were sicker or had more sickness when they were children, but there's reactivation because they've got no IgG to keep them under control. Yep.
You mentioned hypersomnia. Is that irrelevant?
Hyper?
Yeah.
Well, people are exhausted. They're just really exhausted, and it's mainly interleukin-6 that's probably the factor in that, and it's also the extremely high load from everything else, They're exhausted. If I didn't mention that, that was a big omission. They're tired. Yes?
In late-stage Lyme, and you're talking about in terms of encephalopathy and neuropathy, does it get harder to treat than if you caught it earlier?
Absolutely.
How long do you wait with your oral antibiotics before you go to Lyme?
Well, that's a clinical decision. So I think what people generally are doing, again, we don't have any big studies. We don't even have this accepted. There's no budget. There's very little NIH budget on this. So what we do is we treat somebody for a month with what seems to be the right antibiotics to start with. And if they're getting better, we continue or we layer on something else. It's when they're not getting better that we switch to IVs. One more.
Start antibiotics presumptively, or are you required to show to insurance companies an absolute diagnosis? And if so, are spinal taps required the way they are in tertiary syphilis?
No. So I don't think my patients are having any trouble getting reimbursed for their medications. I'm out of network, so I don't know what they get back for seeing me in out-of-network benefits, but we can prescribe antibiotics.
Is it covered by Medicaid and Medicare?
Yes. Although the Infectious Disease Society of America is trying to, what do they call it? They've been putting out lots of bulletins over the last few weeks that they want to have somebody in charge of antibiotics in every hospital to be a monitor, and now they want to put it into our private practices so that we can only prescribe antibiotics as it fits their guidelines, and they're going to implement and enforce this starting with Medicare and then through the insurance systems. And so they want to be the gatekeepers so that once that happens, nothing will get reimbursed. Somebody asked about, is it harder to treat later? And the answer is yes, which is why I think everybody should be treated aggressively for a tick bite. So I never started out to really treat Lyme disease. You know, I just want to get my psychiatric patients better, but I want to keep people from getting tertiary Lyme. So I have sort of opened up my practice to whoever, you know, mainly it's by word of mouth, that I will see anybody who's been bitten by a tick within 24 hours. And if I have to see you in my home on a Sunday, you know, I'll see you in my home because I want you to get the right treatment. I don't want people getting this sick. I want them to get treated properly initially. And I think it's correct to offer people different choices for how aggressive they should be when they get a tick bite. So I do a lot of education and I let people decide. I mean, some people would like to be treated for Babesia or Bartonella when they get a tick bite. It's very easy at that point, and making that diagnosis is so incredibly difficult because they're intracellular organisms, and they're very hard to get rid of. Bartonella, it's very difficult to get rid of these. So some people would say, you know, I got a tick bite, treat me for Bartonella for a week.
When we order routine medical labs for a patient, what would you add to for the very first time? You wouldn't obviously add that whole long, you know, medical lab regimen. Like, is there one or two things that we could add that could really help us from that standpoint?
I would do a CD57 on everybody. I would do a C3A and a C4A on everybody, and a Western blotted Igenex.
Thank you so much, Jane.
Okay,
Okay, thank you.
great. Thank you all.